Recording started in the transcription. Yeah, so it started. I will put bring the screen again. Yeah. So I will just put the 3 minutes timer. I want this to be here so I can see. Okay. This is the 12 minutes, and this is 7 minutes. I want it 3. So these are 3 minutes timer. Don't worry. Okay. And then we need to decrease this font a little bit so you can see. Okay.
Yeah.
Are you happy to start?
Yeah.
Yes. So I will put the 3 minutes timer. When you read until the plan, let me know so I can, I can show you what is down there because there is still some little bit of information.
Yeah, sure.
Shall I go down?
Yeah, please. Oh, I did not realize that you have.
No, there is a lot down, so. You want to bring the beginning of the case?
Sorry, if you just give me a minute, I'm still looking at the.
Take your time. Okay. This is the last blood
Yeah,
pressure.
if you go a bit, scroll up, please.
Yeah, sure.
Sorry, plan number 3. Can I just have another look? Okay, bloods to assess. Okay. Yeah. Hi, I'm Rizwana, one of the doctors from GP surgery.
Yeah,
hi, am I speaking
doctor.
Hi, am I speaking to Jessica Brown?
Yes. Thank you very much, doctor, for calling you.
Hi, Jessica. I could see that you have some blood test done very recently, and one of my colleagues started you on steroid tablets.
Yes.
Is our consultation regarding your review and to discuss blood test results?
Yeah, well, really, yeah, doctor, yeah, because really, I don't feel that this medication is working, doctor. I feel more knackered, to be honest, and I'm more tired. The pain are not going, and I feel more weak and weak. I think
Okay.
these tablets are not working. And then when I read about the, the steroids, I find that
Mm-hmm.
they are very bad. And he didn't explain that to me. And even he told me you have BMR. I don't know what his
Mm-hmm.
BMR is. I didn't get
Okay.
what exactly
Mm-hmm.
is happening.
Mm-hmm. Mm-hmm.
So yeah, doctor.
Okay. I'm really sorry that you are feeling that way. Your symptoms did not improve at all. Definitely, we could work together to figure out what's happening at the moment. I
Thank you,
have got
doctor.
your blood test results, but is it okay if I ask you about your symptoms first so that I could put it into context?
Yeah, sure, doctor. Yeah, please.
Okay. So when my colleague said PMR, it's usually we called polymyalgia rheumatica. So it's one kind of condition when our body started fighting against our muscle joints and causing some aches and pain. If
Oh,
it does not respond to steroid, we need to think about other cause. I believe it would be a bit unlikely to have PMR. Okay.
okay.
Okay. So
Okay.
can you
So he
walk me
think that
through?
my body is fighting against himself. Okay. But you
Mhm.
don't think that. Okay. Yeah, you
So
relieved me. I was very
yeah,
worried. Yeah.
like
Okay. Yeah.
if it responds to steroid, then it's a bit of confirmatory because it's clinical diagnosis. But anyway, can you take me through your pain and stiffness, please?
Yeah, to be honest, all of the things started after I went to do this dentist. Okay. I went to the
Mm-hmm,
dentist. I had tooth problem. I have been
mm-hmm,
there for a while, to be honest, doctor. And it's
mm-hmm,
pain to have a dentist under in the chest. I had to go privately, and he cost me leg and arm, but what to do? And then he fixed my tooth, but then after that, I started to have all of this pain. Very, I cannot even turn in the bed at night. I cannot stand up from the chairs because of the pain. I feel very weak shoulder, and now after we start the steroid, I feel that things are becoming more worse. I feel completely knackered. I can't do
mm-hmm,
anything, doctor, at all.
mm-hmm, mm-hmm. Okay. And I'm really sorry to hear that. And you said the pain, is it on your neck, shoulder, and your pelvic area? That means your hip
Yeah,
area?
exactly. Yeah,
Mm-hmm.
exactly. Yeah, it's around my
Okay.
pelvis, and
Mm-hmm.
my hips, and then also yeah, my
Okay.
two shoulders. Yeah,
Mm-hmm.
doctor. Yeah.
Okay. How long the stiffness last for you?
But to be honest, it's all the day. I'm stiff all the day. I feel I'm stiff all
Mm-hmm.
the day. I'm not sure.
Okay. Mm-hmm. Okay. Any unintentional weight loss?
No, I didn't lose any weight. Actually, I put
Mm-hmm.
some.
Okay. Okay. Any fever?
No, I didn't have any fever, doctor.
Any night sweating?
Well, no,
Mm-hmm. Any lumps or bumps anywhere?
lumps or bumps. No, no, doctor.
Mm-hmm. Any changes in your bowel habit?
No, I'm going regularly.
Mm-hmm. Oh, that's good. Quite reassuring. Any blood in your urine or during opening bowel?
No, I didn't notice anything related. No, I'm not bleeding
Mm-hmm.
from anywhere.
Any tummy pain or any bloated tummy?
No, no.
Mm-hmm. Mm-hmm. So your symptoms are going on for quite some time. How does it affecting you? You said you could not sleep well. By any other way, it's affecting you?
No, doctor is just making me feeling knackered. I'm living
Mm,
alone. I need
mm,
to cook and clean for myself. Now I
mm,
cannot do, even
mm-hmm,
my clothes, there is a pile of clothes there in the room I cannot even
mm,
wash. I feel very
mm,
tired. Even sometimes I'm hardly standing from, from the chair.
mm. Okay, okay. Um, by any chance, your pain has affected your mobility?
Well, yeah, my ability now is limited. I don't have the strength to stand up. I feel dizzy
Mm,
with when I
mhm.
try to stand up, I feel very weak and dizzy, plus the pain.
You feel weak and dizzy.
Yeah.
Okay. Do you feel like, how do you explain the dizziness? Is it lightheaded?
Well, I just feel that I will faint.
Okay. Okay. Any chest pain?
Well, not just pain, but funny. I feel sometimes I feel, I feel my heart is fluttery little bit, but then
Okay.
it's will return to normal and then sometimes fluttery. Yeah. So yeah.
Okay. And that's fluttery sensation going on for how many days?
Well, the same, I think, all started after this dentist playing my teeth.
Okay. Okay. Um, and you said it's really difficult to even get up from the chair. Is it because of the dizziness or because of the weakness?
Well, because of the weakness, I don't have the strength.
Did you notice any muscle wasting by any chance?
No, no muscle wasting. No, I think my muscle is fine, and I feel that I gain weight even. No.
Okay, okay. Anything going on in your mind which could be contributing to your symptoms?
Well, I was always thinking maybe something related to my teeth. I don't know, doctor, because I
Did it?
didn't find, yeah, I didn't, all these symptoms didn't start except after my teeth thingy.
Okay, okay. Any headache at all?
Well, not headache, but
Mm-hmm.
I feel the dull, dull ache around my neck, but no headache in my head. So,
Mm-hmm. Are you
yeah.
able to do a neck movement? Like, can you turn your neck?
Yeah, I can. Yeah, I can.
Okay.
It's stiff little
Mm-hmm.
bit, but I can.
Okay. Okay. So, definitely you said like you were quite worried about your symptoms, but anything in your mind that I could do today to make you feel better?
Well, doctor, I don't know if you can just
Mm-hmm.
find a way to,
Mm-hmm.
this pain and tiredness and the stiffness to go away.
Mm-hmm.
That's all what I was hoping of.
Okay. So, thank you for letting me know all those information. So after talking to you, what I'm thinking at this point, it would be really good to examine you. The reason is you said your fluttering sensation in your heart. So I would like to check your blood pressure, your heart rate, and I would like to listen to your chest, and I would like to examine your joint. Is that
Okay.
okay?
Yeah, yeah, sure, doctor. Yeah.
Okay.
But are you
So
thinking of anything specifically?
if I'm honest with you, I don't have any specific diagnosis in my mind, but what I'm thinking, probably all of your symptoms happening after an episode of infection. Okay.
Uh-huh.
So
Uh-huh.
when we did blood tests, we found few things. Okay. So your
Yeah.
inflammatory markers are raised in your body. Okay.
Okay.
So
Okay.
because of that, I'm just thinking there are some other specific uh, arthritis related blood test what we could do. Okay. So I'm
Mm-hmm.
thinking that would be an option to do few more blood tests. Okay. And the reason I would like to repeat the blood test is one of your blood marker which showed blood sugar controlled in last 3 months, that's on higher side as well, which is in diabetic range. Sorry, are you with me? I'm telling you a lot in
Yeah,
one
yeah,
go.
no, I'm with you. Yeah, I'm getting
Mm-hmm,
you, but it's just a few
mm-hmm,
things I'm not getting. So you
mm-hmm.
said that I've arthritic. I'm not sure to what we are worried about other arthritic thingy. I didn't get. So is there have
Mm-hmm.
inflammation in the joint? This what I'm trying to say. Because in the
Yeah.
beginning you said
Mm-hmm,
doesn't look BMR something.
mm-hmm.
So
So
yeah.
so this polymyalgia rheumatica, I said usually it responds to steroid.
Okay.
As you did not see any improvement, so I believe stopping steroid will be a good starting point.
Okay.
However, we need to do some other test to see why you have got that kind of pain because your inflammatory markers high in your body. So a medical condition called rheumatoid arthritis,
Mm-hmm.
in which condition people's like stiffness tends to last longer. I'm just thinking if we
Okay.
could do this test to get
Okay.
a clear confirmation. Okay.
Okay, yeah, sure. Yeah, that makes sense. Yeah, please. Yeah, I will
Mm-hmm,
stop this steroid. Yeah, it was not good for
mm-hmm,
me. I didn't like it.
mm-hmm.
Yeah, I will stop it, doctor. Yeah,
Okay.
so do you want me to come today?
So today for examination, and
Mhm.
shall I just quickly go through the test results? Like I said, I would like to see those specific marker, though the medical condition I discussed, it usually affects the small joint. However, that's a possible diagnosis. Either we need to confirm or we need to exclude. So
Okay.
when we will repeat the blood test, I would like to see that you are still the diabetic level or it come back normal? Because after steroid, that could happen, but you had on very short dose. It's a bit unlikely that steroid is making you diabetic, but repeating would be a good starting point. Are you with me?
Yeah, sure, doctor. Yeah, that's clear. Yeah,
I'm really sorry. A few more things I need to discuss with you.
sure.
Your blood picture is showing you are anemic. However, you said you did not notice any blood in wee or
No,
opening bowel. So I
mhm.
think it would be a good idea if we are doing a urine test to see if you are passing any blood in your urine. We
Okay,
need a stool sample test to see if there is
okay,
any blood there.
okay,
Is it
sure.
clear so far?
Yeah, sure, doctor. Yeah, no problem. Yeah,
So
I'm
in
happy
terms
with
of
that.
your pain medication, what do you think we could do? Do you like to try with paracetamol in the meantime?
Yeah, no problem. Yeah, I'm
If you
happy.
want, you could try with like ibuprofen as well, because your kidney function test is fine. If you don't get tummy upset, that would be a good option to try. Are you okay with that?
Yeah, sure, doctor. Yeah,
I'm
I'm
really
happy
sorry
with
I
that.
gave you lots of information in one go, but I will examine you, we'll repeat the blood test around a month time. Thank you.
Thank you. Yeah, sure. Ah, breathe.
I don't know, Salim, what's going on.
Yeah. No, it's a difficult case. It's a difficult case. It's not straightforward case. But I actually, you did fine. I'm happy. I mean, yeah, there's slight tweaks we need to do, okay, and the concepts. But in general, your structure was excellent. I like the structure. We'll talk through it, okay? So just reflect on what you would may do differently if you repeat this case. Hello?
I don't have much differentials in my mind, and that's why I struggle to ask you
Yeah,
questions.
so this is what this is the problem. This is what I felt like, yeah, but
Hmm.
you know, the management plan is fine, okay, is because there's no much management plan to be honest in this case, except if you have a proper differential. Okay, so in the differential, I would like to hear more, and I would like to know why you are asking. Okay, because you are kept asking, oh, you have tummy pain, you have night sweats. But the patient doesn't know why you are asking all of these questions. You did make the things more clear in the second half in the management. Well, yeah, because there's other differential, but then you said rheumatoid, and then you didn't ask the question about rheumatoid up. So he was not clear what is happening there. That's why he was in the management little bit hesitating what to do. But if you follow a proper differential up there, and actually
Hmm.
in the data in the information that they give in this case, they give you a bit of clue what might be going on. Do you know where is that?
You kept saying like tooth abscess and followed
Yeah,
by everything
tooth, yeah.
started.
Tooth. I
So
replied this. So if the patient or an actor replying something, so he wants to guide you for most probably the right way, but also he can guide you to the bad way as well. So just be cautious. But there is something there. Either he want to guide you to the bad way, so you will correct him, and they will know that you are self-confident and you have enough experience and knowledge to correct him. Okay, his belief. Or
mhm.
he is trying to guide you because the case is a bit difficult and they want you to go to that way, and you will just follow and explain. Okay, so if he say tooth abscess, then there is some hint there of something happening may help you in the in such case. What do you think?
I could not think of like tooth abscess and then followed by joint pain. In which
Mm.
direction I'm going to?
Yeah,
I'm sorry.
No problem. I will let you know. So what else you would change in your differential?
Like you said, I need to signpost when I asked you like
Yeah,
low hemoglobin
yeah,
questions, related
yeah,
questions, because
yeah,
patient
yeah,
does not know. I was thinking
yeah,
about
yeah,
bleeding,
yeah,
then ovarian cancer
yeah,
and all those things
yeah.
to correlate.
Yeah, so
And
okay, yeah,
then I did not get chance to ask anything regarding lifestyle questions. I
yeah,
did not ask you about your occupation. All I asked, like, how does it affected you? And you told me
yeah.
about sleep and everything. I need to ask about mood. Because you are
Yeah,
not
especially
sleeping.
especially he's not
He lives
sleeping,
alone.
living alone. Yeah,
Yeah.
so all of these things.
So I did not ask
Okay.
about mood questions.
Yeah, but
What else?
he did volunteer some of the data there. Okay.
Mm-hmm.
He told you that I live alone, I'm struggling, which you may add it in your management. But I guess if I saw this patient, my management plan would be trying to refer him as soon as possible, and I will explain why. But maybe after he come from the hospital, what we will do next, you may signpost him to either the frailty team or, social prescriber to, provide him with some support at home until he completely cure and feel that he is fine. So this one of the things that you need to think about it, okay? What else you noted there in his data? His hemoglobin A1C not controlled. Yeah, he's anemic, but also there is some subtle change.
Cholesterol,
Well,
high
cholesterol,
cholesterol,
yeah,
ALT just borderline.
yeah. Well, all of this can denote something. Okay, can denote something. Not the cholesterol, to be honest, but the ALT in the higher side can denote something. But if you look at the differential of his
Mm-hmm.
of his white blood cells, what about the neutrophil there?
High neutrophil.
Yeah, so what that can may denote?
Like some inflammation.
Yeah, this is a lift shift. So lift shift, that means that there is a bacterial infection happening somewhere. It's very subtle, maybe masked
Okay.
by the corticosteroid. We don't know. Maybe
Mm,
masked by his diabetes or stress-induced hyperglycemia. We still don't
mm-hmm.
know. But what
Mm-hmm.
is shocking here that his
CRP.
CRP is high in the sky. CRP
Mm-hmm.
120 is something
Mm-hmm.
alarming to any physician. It's not
Mm-hmm.
something you need to take it lightly. This
Okay.
CRP is above 100. You
Mm,
should not take it
mm-hmm.
lightly at all. So when CRP is high at this level, either this is connective tissue disease and it's progressive, either this is malignancy and it's hidden, either this is sepsis and it's also hidden. So three of them are major alarming diagnoses that need rapid interaction from you, not to take it lightly. Okay.
Mm-hmm.
And already they give you a hint and you pick it up that already we give him high dose steroid. We give him 12.5 milligram of prednisolone, which is, or 15 milligram prednisolone, which is a high dose. If this is a polymyalgia rheumatica, at least he will if he is not resolved completely after 2 to 3 days, he will show some improvement. But the patient told you, no, I didn't improve. I become worse. So this is an alarming. All of these an alarming, subtle changes in the presentation of the patient.
Hello, Salim. Sorry, you
Salim, we can't
muted
hear you.
everyone.
We can't hear you.
Can you unmute yourself, Salim?
Do you hear me?
Yes, we can hear you
Yeah, you hear
now.
me? So,
Yes.
and where everyone listen to me until when? Sorry. What
Just like
what is
30
the
seconds ago, you were
so
saying
I
like
mean,
CRP.
yeah, okay. So CRP above 100. Okay.
Mm-hmm.
So polymyalgia rheumatica, CRP will be 40 to 50. Okay. More than that, you need to exclude certain things in your mind. Okay. If the CRP reach 100 and above, this is an alarming sign of hidden malignancy or hidden sepsis, okay, or hidden connective tissue disease, like rheumatoid arthritis and and other connective tissue diseases, not simple polymyalgia rheumatica, okay, because yeah, polymyalgia rheumatica consider an autoimmune disease, consider an inflammatory, but it's a subtle one, okay. The other major ones are rheumatoid arthritis, or if you have, vasculitis like giant cell arthritis. These diseases, the CRP will be very high. Okay, so these are the things that should be in your differential. and this is what you should exclude. In the data that they give it to you, the patient already had an abscess, and who knows this abscess was there for how long. And do you know that, dental abscess can, can send seedling of bacteria to either to the heart, to the bone, or to the intervertebral joints, and cause this what's called the discitis. Okay, so these are the things that can cause hidden sepsis, either subacute bacterial endocarditis, either subacute osteomyelitis, or subacute discitis. So these things should be in your differential, and the only way to know that is to bring the patient in, examine him, and even if you're still not sufficiently sure what is happening, you may send him to the SDIC or even to the emergency department to do further investigation. Okay, so CRP 100 shouldn't be taken lightly. Okay, this is what I'm trying to say. So in your reflection, yeah, I like the way that you prescribe the BMR, but if you said to the patient your body is fighting, I will start to worry. What does it mean my body is fighting? This is a big word, to be honest. Fighting,
Okay.
your body is fighting its own. If I told you this and you are not a doctor, you will be a little bit worried. You can just simplify the things. Well, you have just swelling and inflammation around the soft bits around your neck and pelvic girdle. You don't need to go in details why the inflammation happened, except if the patient start to ask. Okay, yeah, it's sometimes your immune system can mistakenly make unnecessary inflammation. But don't say fighting, don't say attack, don't say, these big words will make the patient worried. Okay, you don't need the patient to be worried. Yeah, you want to address the information to him, but you need him to be calm as well. Okay.
Okay. Yeah, sure.
And then you said, okay, when you start to ask him, just address the things. Okay, well, because you may start with the addressing of the blood test. I can see your inflammatory markers a little bit high. You have something called CRP with 120, is a bit above normal. I need just to ask you some further question to make sure what is happening there, to have better understanding. Sometimes the CRP is high if you have, infection and hidden infection in your body. I can see that you have an abscess. It could be related your tooth abscess, but let me ask you some few more questions. Did you have the temperature? Okay, and then you say, okay, have any change in your bowel habit or diarrhea or what, or the other, screening question regarding sepsis. And then sometimes if you have a hidden growth, or what I don't mean to make you frightened. If we had hidden malignancy, that can be, I'm not saying you have malignancy, but I'm just trying to be thorough. Okay, and then start to ask about malignancy. You can ask about only the cardinal signs and symptoms, which is my unintentional weight loss, night sweats, and and excessive fatigue and tiredness. It would be enough to exclude, massive malignancy happen here or there. Okay, rather than be directed to certain malignancies, because the differential in such case is wide. You can use the broad term of it. Okay, you need not to go to every differential in details. Okay. Is that clear? And then when you
Yeah.
bring him in, just in the differential, I would like to hear a couple of things. If patient suspected polymyalgia rheumatica, you need to exclude giant cell arthritis. Okay, so if you want to exclude giant cell arthritis for this patient, what you would ask him? What are the questions?
I asked you about headache, but I should be
Yeah, but
specific. Is it on
yeah,
the side of
so
the
yeah,
head?
well,
Any?
it's not, yeah, it can be headache, but usually,
Mhm,
usually
mhm.
it will not present with headache. Well, what else?
It's a skull pain. When they are coming, they will feel pain
Yeah,
with
so yeah,
chewing food.
skull pain when you're, yeah, exactly. So
Mm.
TMJ claudication, okay, TMJ claudication, which is pain while you're chewing food. Okay, what else? Because it's important in your
Visual changes.
referral. Visually changes, because if you have visually changes, it's urgent referral to the emergency department for pulse steroid. If there is no visually changes, you can call rheumatology and start oral tablet until seen by the rheumatology within 3 days maximum if giant cell arthritis. Okay, so after excluding the giant cell arthritis, what you said rheumatoid arthritis. So how you would exclude it? What is the question that you would like to ask the patient?
I asked you about stiffness. You said all the time the stiffness is there.
Yeah, well, yeah, can be. Well, in advanced rheumatoid arthritis, you would get some stiffness, but also you need to, and you said small joints, it's important to ask about the small joints because if the small joints again of the hand and the foot
Hands
are
and feet.
affected in
Okay.
rheumatoid arthritis, this is an urgent referral, okay? So
Mhm.
I would, if I am an examiner or supervisor, I would like to hear these questions, okay, from you. And then in the management plan, you will, well, the patient doesn't have a much of ice. He just need to get rid of the things and you want to know how, want to have ideas about what is happening. So addressing the ice actually will be addressing the differential diagnosis and then what is your next plan, which is bringing the patient face to face. I want to examine you. You need to nominate what you want to examine. Yeah, you said urine depth for the anemia, you said maybe fit test, yes, but you need to say, I need to listen to your heart to see if there is any murmurs, and this is important, okay, because if subacute bacterial endocarditis happened, you may get some new onset murmurs, okay, and you need to see the entries of the previous doctor if he documents any heart murmurs or not. And the other thing, if any tenderness over the spinal process, okay, I would like to hear that if there is any tenderness over your bones or joints, okay.
Mhm.
Uh, and then, yeah, you will do further testing, but then you tell also the patient, if I couldn't find a sufficient cause of explaining why your CRP is high, I may call the hospital just, to be seen in the SD codes, same day emergency department clinic, just to be assessed more thoroughly with further investigation. Okay, yeah, you may send him for blood culture and do sepsis screening. Okay, this patient will not have what is called hot sepsis, okay, because sepsis is, there is two phases of sepsis. You have hot sepsis, which the patient will present with the systemic inflammatory response, which is temperature, rapid heart rate, rapid respiratory rate. But in cold sepsis, which can be hidden by the chronic inflammation, this is one, and by the steroid and probable diabetes, this can modify the the immune response to the sepsis and make it, and make it subtle. He will not, present with the typical symptoms of hot sepsis. Okay.
Mhm.
Yeah. So this is my input regarding the case. I'm not sure if anyone have question um, or queries. But the
Salim,
structure is very good. I like the structure.
just
Okay,
one
it's
question.
not an easy case. Yeah, sure. Just who is talking? Yeah, just can you tell me your name? Who's talking?
It's,
Rizwan?
it,
Yeah, Murtaza?
Sorry.
yes,
Yeah, yeah.
Salim, this scenario it looks extremely busy. I mean,
Well, no. You will find some cases 3 and 4 A4, papers in the exam. Not you will not not all the cases will be one, some cases will be 2 3 papers, okay. If you ask the people who took the exam, they will tell you some cases will, and they examine by this, by that they examine how you can screen the important pits and this data. So all what I can say that is important here is 2 3 things, yeah. So patient had a tooth abscess. Patient have PMR. We started him in the PMR protocol, and so he should, improve. And then scrolling down, nothing is there. Slight anemia, maybe relevant, maybe not. The neutrophil is little bit high. All the other are normal except the CRP and the hemoglobin. That's it. That's for information. 4 information or 5 information, you will be able to gather them in the 3 minutes time. Yeah. Hello.
Yes.
I think now, Salim, after your feedback, I'm just thinking like how I could do it better. So probably like the way you say it, definitely it seems the biggest differentials is inflammation. It could be all those system that you mentioned and malignancy.
Yeah,
So
yeah.
if I
So
just tell the patient,
so if there is a lot of differential, okay. I
mhm,
mean, personally, I will pick the three most important, okay, for the sake of
mhm,
the 12 minutes. I will pick the three most important, and this what I will ask regarding them, okay?
yeah,
So,
okay,
yeah, and in this case will be the sepsis, will be the malignancy, will be connective tissue disease. So these three, if you ask about them, will be more than enough
okay,
for anyone listening to you.
okay,
Okay?
yeah, sure.
Yeah, and it's not uncommon case. Okay, I'm not talking regarding the exam, but I'm talking also regarding the real life. PMR is a potential case for sure the exam. Okay, well, because it's a common thing, it's not uncommon. Okay, but the differential is also common. This case was in the coroner court some time ago. Okay, and because of missed diagnosis, something like that. Okay, so and it was in one of the teaching session that we got in our dinners. So it is a case, and you may face it in your real life. So just be aware about it. Okay.
Sorry, one
Um.
question, Salim.
Yeah.
Can I ask one
Sure.
question?
Sure.
You said like giant cell arteritis will do urgent referral to rheumatologist for temporal artery biopsy, and we will start medication in primary care if
Yeah.
there
You
is
can
no
start.
visual impairment. Is it?
Well, if there is or no visual impairment, you need to start the steroid, okay? Because
Okay.
the giant cell arteritis is not a simple disease, okay? It's eye-threatening condition. It's
Mm,
medium to large vessel vasculitis, so it can cause aortic vasculitis or aortic branch vasculitis, which is nasty, and the patient can lose his limb or even have a stroke because of it. So giant cell arthritis, once it's suspected, need to be treated. So you will start the steroid after calling for sure the rheumatologist. And then if you are talking about our ordinary, you have Norwich Hospital, they have 24 hours, 24/7 rheumatologist where you can call him and he will accept cases on the base of suspicion and he will see her in the same day. Okay. Other dinners, I don't know, but according to the CKS guidance, so if there is eye symptoms, should be assessed by the rheumatologist in the same day. If no eye symptoms, will need to be assessed by the rheumatologist within 3 days, and then both of them you need to start the pred. If there is eye symptoms, you will start a higher dose, which is 100 milligram a day. If it's no eye symptoms, you can start from 40 to 70 milligram a day. Depends on what is the other comorbidities that the patient have, his diabetic, hypertensive, his age, and calling for sure the rheumatologist and let him know about it. If not, then you can send to the emergency department. No one will tell you no. Okay. But
Okay, yeah, sure.
but to be have high suspicion, yeah, giant cell arthritis is not a thing that you need to miss.
Mhm,
Okay, and the
sure.
overlap between it and polymyalgia rheumatica is around 50%. So
Mhm,
usually when there is one, the other is there. So you need
mhm,
just to look it and then you will find it. Because if you
okay.
don't know it, you will not look it and then you will miss it. And this is the problem.
Mhm,
Okay. The other thing that I want to say is the response of polymyalgia rheumatica to the steroid should be within 2 to 3 days. The symptoms will improve. Okay. And then the problem will be in withdrawal of the prednisolone. Okay. And then, prednisolone withdrawal for polymyalgia rheumatica need at least from 1 to 2 years. So these patients need to be having PPI to protect their gut. They know exactly the side effect of the steroid. You need to follow up their sugar and their blood pressure and the cardiovascular risk overall, and uh, and you need to do gradual withdrawal of the prednisolone. Okay, and I will show you the scheme how to do the gradual withdrawal of the prednisolone.
So
Is
in this
that
particular case, do we
yeah?
need to tell the patient that patient could stop the medication?
Yeah, he need
Though
to stop the
10 days.
medication. He need to stop the medication if you are sufficiently excluding the giant cell arthritis and rheumatoid arthritis. Then he
Mhm.
need to stop it because actually this patient have a septic, has sepsis, subacute endocarditis, and that's why he have the CRP high. And keep giving him the pred will just make the inflammation more and more. Yeah,
Okay.
and actually, even I think the initial culture was negative, okay, because the bacteria was atypical, or there was fungal infection, something like that, because of the pred. And then with subsequent blood culture, the infection appears. Yeah, okay.
Thank you.
Yeah, no problem. I will go through this slide of the giant cell arthritis, and so let me just open that. So yeah, if you can see this diagram or algorithm, yeah, you can see the typical sim age is 50 years old, and you know the pains are around the shoulder and pelvic girdle, and the stiffness should be more than 30 minutes. And then the inability to perform, the usual daily activity, and problem with the sleeping during, he cannot turn around during the sleeping. This is one of the main symptoms. When to refer also for BMR, because BMR you can treat at the primary care if it's early onset and you are sufficiently sure that this is a BMR, so you can send him for the rheumatology to be further investigated. The differential, you can see it's infection, rheumatoid arthritis, endocrinology. It's a very vast, wide variety of differential diagnosis, but I would pick the infection, the malignancy, and the other connective tissue disease, okay? Especially in such case, they give you a hint that there was a tooth abscess, so there is some red flags towards the infection, okay? And that's why you need to use every single uh, information on the data that they are giving to you to try to guide you and connect it to the case in front of you, okay? These are just
Sure.
repetition of what I said. I don't think we need to go through any of these. Investigation, yeah, these are the investigations, the inflammatory marker, and the overlap between the GCS and the BMR. Okay, and you can see 50% of people with GCS may present with BMR symptoms. Okay, and 20% with BMR have GCA. So always think of GCA, please. Okay, and these are the symptoms. We already went through that when I discussed with Rizwana about how you can suspect the GCS. And yeah, so I did, most of the things I did explain it in the discussion and when to refer. And then this is the important thing, how to withdraw the PRED, because it is really a pain to withdraw patient from PRED and the RPMR, okay? The patient will struggle and you will struggle until you are able to withdraw it. And usually the maximum dose of the PRED should be 25, and then you reach stationary base level control of pain for at least a month, and then you can then start tapering it by 2.5 milligram every month until you reach 10 milligram. And then after that, 10 milligram for a month, and then reduce it by 1 milligram each month. To be honest, the most difficult bit is to decrease it from 10 milligram below. Usually, when I try to remove the 10 milligram to 9 or 8, the patient will start, to have the symptoms again. And the issue is there is massive change in their daily activity. They are feeling stiff, so they will be like hooked on the PRED. So I intend, to be honest, to decrease it rather than 1 milligram every month, I intend to decrease it 0.5 milligram every month. And then for sure, 3 monthly full blood count and, checking for the diabetes and the cardiovascular risk. Plus, please don't forget these patients need FACS score and DEXA scan, okay, in the beginning and then maybe by the end of the treatment, because you can repeat the DEXA scan. Do you know, guys, doctors, when you are allowed to repeat the DEXA scan, what is the time frame for repetition of DEXA scan?
Is it 3 to
Is it
5
2
years?
years?
Yeah, it's above 2 years. So so you can do it at 3. You can do it at by the end of the second year. Okay. So I intend to start when I start the PRED and I'm sufficiently have the suspicion or the confirmation by the therapeutic trial of PRED that this is a PMR. I will do a DEXA scan in the beginning. If the DEXA scan and the FRAX score is showing that the patient have osteopenia or osteoporosis, I would start him for bone protection, either, if osteopenia, vitamin D, calcium, and if it's osteoporosis, I will start the alendronic acid. Did anyone here know what is the drawbacks of alendronic acid, please? What is the contraindication? And I need also how you will tell the patient to take the tablets. Can anyone please unmute himself and participate? Doctors?
Yeah, I mean,
Yeah.
I can say it.
Yeah,
So
sure.
the side effect of bisphosphonate is it can damage the jaw. It can cause
Okay.
inflammation in the food pipe and stomach.
Okay.
And sometimes it can rarely cause fracture of the femur bone.
Uh,
And the way, yeah,
yeah. Go ahead. Continue.
and the way you will take it, I will advise my patient that you need to take this medication sitting in a chair and bed, and take it on empty stomach. And please don't lie for 30 minutes because it can cause irritation of the food pipe or stomach.
Okay, excellent. Yeah. Just two things that I needed to be cautious about. Don't say damage to the jaw, okay? Say it can cause, difficult or it can cause massive inflammation in the bone of your jaw. Because if you say destruction of the jaw, the patient will not take it. Okay? Yeah, you need to be obvious with the patient. That's fine, okay? But not just reward. Make rewarding of your explanation, okay? No need to say destruction, because if you told me destruction, well, I will not take it. And if you told her that she may have fracture of the hip, so why then I will take it? It's something I will avoid it. And actually, it's not causing fracture of the hip because I'm not aware, to be honest. Who told you that it's causing fracture of the hip? Because you are taking it to protect the hip from fracture, isn't it? So,
So
I
it's
uh,
think it
very
causes,
rare fracture. Very rarely it could happen.
pathological. Yeah, okay. So don't pick these, the rare side effect and start telling it to the patient, isn't it? So say the common things, yeah, which is the jaw, okay, and then say about the GI problem, okay. But then if you say to the patient can cause you hip fracture, so why I'm taking it? If it will help me to avoid the fracture. Does that make sense? Because how you will explain that to it, even if it's rare how you will explain that it can cause Murtaza, are you there?
I am
Hello?
listening. Yes,
Yeah. So
yes.
how you will explain that to the patient that it can cause fracture to the hip?
Yeah, I mean, I can see it's given for the prevention of fragility fractures, but this is what we kept on memorizing, that these are the three common side effects.
Yeah, okay. Hmm. That's fine. Okay, I will search it because I know that I read it somewhere that can really cause fracture. No problem, Rizwana. You can go. Yeah. Thank you very much. Thank you very much. Don't worry. So Yeah, I think it may cause it in the long run if you use it more than the time frame for bone protection. You got what I mean? This is my explanation.
Mhm.
So because you
Right.
will use the biphosphonate from 3 to 5 years, you may extend it to the 10 years for certain population, but then over the long run it can make your bone weak, your hip joint weaker, but not in the protection time period. You got what I mean? And if you
Mm.
have sufficient stores of calcium and vitamin D, that should decrease such side effect. Okay, I will double
Okay.
check it and I will post it. Okay, because this
Okay.
is the what I can this is what I can remember from my previous studies. Okay, I will double check it and I will let you know. Okay.
Okay. Thank you.
And then this is that the steroids will need, and this is the visual symptoms, and so most of the things I already gone through it. Okay, so we will start the second case. I will just need to mute, sorry, not to mute, to stop the recording, and then we'll start the recording of the second case. Stop.